to Detangle, where we untangle the complexities of life, one conversation at a time. I'm your host, Kinjal Goel, and I'm excited to welcome you for a very special episode today. Our guest for this episode is Professor Dr. Jon Stone. Dr. Stone is a consultant neurologist and honorary professor of neurology at the University of Edinburgh. He has a PhD in functional limb weakness. Dr. Stone is the founder of the website www.neurosymptoms.org, which has more than 60,000 hits per month and has been translated into 12 languages. He is also the founding secretary of the new Functional Neurological Disorders Society. Dr. Stone has won multiple awards and accolades during his illustrious career, the latest of which is the Lord Walton Lecture Prize by the Association of Neurologists, conferred in 2022. I think what is really special about our guest today is that he has been a personal inspiration to me. Welcome, Jon. Thank you so much for honoring this invitation and joining me today.
Thank you, Kinjal. It's very nice to be here to be able to talk about FND and functional disorders.
Yes, and I think I remember, Jon, the first time we met online was when I was working on my book, Blind to the Mind, and we were discussing FNDs and we were discussing so many things that affect the mind and body together. So I'm glad we're able to do this now and bring this information to all our listeners, whether doctors or lay people.
Yeah, certainly it's a very neglected and stigmatized and misunderstood area, I would say, of medicine.
I agree. So to begin with, Jon, could you tell me what is your understanding of functional neurological disorders and how are they broadly categorized?
So I'm a neurologist, which means I'm seeing people with neurological symptoms like paralysis, tremor, seizures, trying to figure out what's causing them. And in our practice, FND is one of the commonest conditions that we see. In fact, although people be amazed about that, it's just as common as conditions like MS. FND describes the situation where people have those neurological symptoms, and they really have them. But they are due to a problem in the way the nervous system is functioning. It's gone wrong, rather than something structural that you're going to see on a scan like MS or a brain tumor. So FND is the functional disorder that we see in neurology. There are many types of functional disorder. So, for example, a gastroenterologist would spend a lot of their time seeing patients with irritable bowel syndrome and other functional bowel disorders.
Right.
They're also functional disorders. So we're looking at a whole family of functional disorders which tend to overlap. And if you have one, you're much more likely to have another.
Wow, that's quite interesting because we always have a feeling that there will be something which we will find even on the emotional gamut when we look at a functional neurological disorder patient. So do you also feel that there is a lot of overlap between other mental health disorders and FNDs?
So yeah, this is sort of at the crux of the issue, really. So for most of the last 100 years, I guess, doctors have been in the habit of assuming that everyone with a functional disorder has a psychological disorder, that they're kind of one and the same thing. So so in neurology, FND used to be called hysteria, which is just about the most stigmatizing name you can have, and but that assumption's not correct. So there is a high frequency of people with, if people have FND, it's quite common for them to have problems like depression, anxiety, and panic. Maybe more than half of patients have that. A lot of them have had issues with bad things that have happened, adverse experiences in childhood or recent stress. So it is really common and it is relevant to many patients. But we also see patients with FND and functional disorders where they don't have depression or anxiety. They haven't had abusive experiences. And health professionals are sort of insisting that they must have done when they haven't. So I think we need a different way of thinking about functional disorders that doesn't just sort of equate them to being a psychological problem. In fact, most of my patients with other neurological conditions also have depression and anxiety, people with epilepsy, MS, Parkinson's. So we need to sort of rebalance the way we think about it, I think.
I think this is a very important point, even from a psychologist's perspective. For example, when I see a patient, sometimes I feel that they have been forced to swallow the anxiety pill and say that, look, you must have been anxious. You must have had stress, otherwise, this wouldn't happen. And the patient somehow starts believing that, yes, there was an instance. People start giving more weightage to their past than probably was even necessary. So, like you say, it may not be, although there is a high chance it could be.
Absolutely. One of the things that was very instructive for me when I did my PhD, I was traveling around visiting people at home, and I was doing long interviews about their life and life events and things like that. And I had a group of control patients who were essentially healthy, and I was doing an interview for them. And I was struck by how much of the time you can make a narrative in almost anybody. Most people, stress is a universal experience. Most people, everyone's had some sort of adverse experience. It's quite easy to make a narrative of adverse experience and stress that fits almost anybody. So that really taught me about the specificity of that. And the other thing that's really struck me is the way that we treat other conditions. So if you're assessing someone with a stroke, for example, and you're trying to figure out why has this person had a stroke, you know that there's a range of potential risk factors you have to look for. Like, do they have a high cholesterol, high blood pressure? Have they been a smoker? And you look for all those things. But if you don't find them, you still make a diagnosis of stroke. And there are plenty of people who have strokes who have never been a smoker. But you wouldn't, if someone says, look, I haven't actually been a smoker, you wouldn't insist to them that they have been. And I think that's often what the experience of people with FND is, that people are insisting on one particular risk factor as being insisting it must be present when in fact it isn't always. So that's a big change for people to get used to, I think.
I think this is so close to my heart. It's almost like you're saying the words I've never found. Because this is so important that a doctor does not create a narrative for the patient, but understands what the real narrative actually is. And this pretty much is the only way somebody can be genuinely helped. Which brings me to your website. I have found it extremely interesting, but I would love to know, how did you create neurosymptoms.org? What was your inspiration? It's been so successful, but how did it start?
Well, it started, I was lucky enough in Edinburgh to have colleagues who allowed me to start being one of the first neurologists really anywhere, I think, who was doing an FND clinic. Because before that, it was sort of considered, why would a neurologist want to be interested in this? But I did have very supportive colleagues, and I was seeing lots of patients with FND, and they are, by and large, pretty complex patients to assess. People with FND often have lots of symptoms. There's a long history. Lots of things have happened, often negative interactions with healthcare professionals, which have to be detangled, a bit like this podcast. And I found it was very hard to squeeze in all the things I wanted to say into a 1 hour appointment. So I made the website initially just to try and help myself and help patients communicate more information about FND, because at the time in 2009, not that long ago, there was zero information on the web, absolutely zero for patients with this disorder. It was completely invisible. Didn't really even appear. It didn't appear in textbooks of neurology. It's just amazing how it had been blanked. So I did it as a practical way to support my clinic, and then was very pleased when other people found it helpful as well. And been pleased that it's had an upgrade in the last couple of years, and there's an app as well. But I think perhaps more importantly, what that helped to stimulate was patient-led organizations like FND Hope, FND Action, FND Dimensions, and there's a number of them now, where patients themselves have organized information and support for other patients. So it's a tremendous advance in this area when we think about how invisible it's been and how ignored patients have been.
Actually, I think it still is ignored and invisible, at least brushed under the carpet in a whole range of areas, including India, where I work. I see that people understand what is an FND, but not as clearly as probably they would if they just visited your website. So it's all about training yourself, relearning what we know about functional neurology, and it's a beautiful place to visit to get the right information in the simplest form.
Well, I think you're right, Kinjal, that we've made some progress, but we've got a huge way to go. I think it's very hard to change ingrained attitudes about all sorts of things, as we were discussing earlier. I think there are perhaps older colleagues of mine where those attitudes are not going to change. So I'm more interested in sometimes in thinking about how we train our younger doctors to have a different attitude. I think they're ready to have that attitude as well. I was kind of shocked, actually, when I was a trainee, how very caring and expert neurologists I was working with would suddenly change when they were confronted with these patients, from being very thoughtful and caring to being quite dismissive. This is not my problem. Good news, the scan's normal, goodbye. And I don't, there's no criticism of them at all. I think they just didn't have any training. They didn't know what to do with this problem. So they responded to it just in ways that they had learned usually from their seniors.
So, John, this brings me to the most important question in my head, which I have been grappling with for a very long time. What happens sometimes is a senior doctor will pick up the phone and call me up. And while the patient is still in the waiting room or even in front of the doctor for that matter, the doctor will say, "Oh, it's nothing. It's just stress. This is your patient. Deal with him or her. I've done the investigations. The scans are normal. The blood tests are normal. So don't worry about it. It's just stress." And the patient is sent away with a number for a consultation with a psychologist. What I've noticed is most of these patients will not make it to me or anyone else for that matter in the mental health care system because anyway they have been written off. They believe that their symptoms are not important enough. And at some point, they start questioning themselves. So, for example, in India, if you're in a large joint family system and a doctor has outright said it's nothing, it's just stress, the first thing is maybe the others in the family will say, "Look, you're overthinking it, get over it." And the blame falls on the patient. So, I know they don't mean to hurt the patient. Like you said, there's no criticism for the doctors. But what is the simplest way for them to refer a patient to a psychologist?
Well, they don't mean, often I think people don't mean to hurt patients, but actually doctors are harming patients all the time.
True.
And they need to wake up and realize that this is going on, that they need to wake up to the reality of the patient's experience. If their patient's sitting in a wheelchair and can't walk or they're having seizures, those things are actually happening, and they're happening in just as real a way as they are for patients with epilepsy and MS. And as we said earlier, just having this very crude and basic view that it's always stress is not helpful. Even when stress is a factor, if you just blame that alone, it's starting from the wrong point in terms of helping people understand what's wrong. A doctor who approaches a problem like that is going to actively harm their patient very often. And often when they are referred to a psychiatrist or psychologist in that setting, the patient will be extremely defensive and upset. They feel like they're being blamed. They're quite often revisiting past events in their life where they have been blamed for things that probably weren't their fault either, or adverse experiences as a child where they felt they were being blamed or it was their fault. So it flares up all kinds of horrendous experiences for patients, and patients are often re-traumatized by their encounters with health professionals. So I think if doctors really want to help these patients, they've got to start from a different perspective, start treating this functional disorders, patients with them, the same way they would treat anyone with any other neurological condition.
Right. So, what I usually find helpful is if a doctor simply tells the patient, "Look, we need to look at your condition from another angle. Visit a psychologist. Maybe after 3 to 4 weeks of therapy, we can all reconvene and reinvestigate if you're not better." somehow the patient feels validated and is more likely to start therapy?
Well, I think, yeah. So from my perspective, I think there's often just a missing step here. So when you explain to someone that they've got Parkinson's disease,
Mm-hmm.
you don't start by trying to tell them why they've got Parkinson's disease, because we don't really know actually why people. What you start with is what's going wrong in the body in Parkinson's disease. So there is not enough dopamine in the brain, and that's why you've got stiffness, slowness, etc.
Right.
You can come on to why later on, and I think we can do that also with FND. So I think what works much better, I think, is to have a conversation with a patient where you're talking about the mechanism of what's wrong. Why can't they move their leg? Why are they having seizures? It's because there's a problem with the messages going from the brain to the leg. There's a problem with the software of the nervous system, or in the case of seizures, they're going into a trance-like state. So you could talk about the mechanism and then think, well, why would that be? Why would your brain have those problems and not be working properly? Well, one reason might be psychological factors. Even if there aren't any psychological factors that you can identify, if it's just happened, it's just been triggered by an injury or migraine or something, then psychological therapy can still be useful, because we want to retrain the brain. There's a problem with the software, and we want to help sort of reprogram that software. How do we do that in a human being? I mean, human beings are not computers. They don't really have software, but the analogy is still works, and it's very difficult to retrain a brain. You can retrain a brain by talking to someone or asking them to do things, but psychological therapy can help retrain the brain as well.
I think that's a very helpful understanding for new doctors or even senior doctors to start assimilating in their practice. Like you said, don't start with the why, but start with exactly what is happening, and then slowly evolve into the why, and the patient will be more receptive to the suggestions.
I think it's a more natural way of doing things. I think what patients pick up on in these conversations is something weird is happening. Normally when you go to the doctor and you can't move your leg, you're expecting to be told what the problem is first, and then something about how that's happened, and then later how we're going to fix it. And what often goes wrong is the script goes off what it should do. Doctors talk about what patients don't have, which you want to hear that you don't have a brain tumor, but you want to hear what you do have first, and then they jump to these discussions about why it's happened before the patient's had any chance to think about or be told what's actually going wrong in their body. So there's a kind of weird difference that occurs with these sort of conversations, and all that I think health professionals need to do is if they just treat it like they do any other condition, things will go a lot better in terms of the explanation.
True. John, what is your understanding or feeling about migraines? Because I think this is one of those gray areas which is being studied, researched, spoken about. There are no blood tests to, sort of prove the intensity of the pain, but the patient suffers. The scans may or may not reveal anything. It's true pain. I mean, it's debilitating for a patient of migraine, but does this fall under FND? Does it fall under something else? And how do you think it should be dealt with?
So migraine is very interesting, isn't it? I have a lot of migraine, and I sometimes think of that as one of my functional disorders. It's interesting because it does have a slightly different status, doesn't it? People with migraine experience stigma and misunderstanding as well.
Oh, yes.
But perhaps not as much as FND. But most people would accept that migraine exists, and it does happen, and it's not very nice. But it's interesting because it is a disorder of brain function. You can't see it on a scan. So there's never a situation really where you would be able to, you can't confirm a diagnosis of migraine with any scan or test. And yet people accept it as a disorder. And when we're talking about migraine, we say to patients, well, the reason you have a headache is because you have a migraine. And then you might talk a bit about what we know about mechanisms of migraine in the brain, and we've learned quite a lot about that in the last 50 years. And then at some point down the line in treatment, you might talk about risk factors for migraine and things that make it worse. So for example, in my case, I noticed that when I've got a holiday, my migraine improves. And when I go back to work, particularly if I'm talking to people with migraine, my migraine gets worse. So those, to me, are evident as psychological, social risk factors for my migraine, which are important to think about. But I still have migraine, which is partly genetic and has a biological mechanism as well. So I think migraine does have a lot to teach us about how to normalize conversations about functional disorders with patients.
That's very interesting, really. Also, on a more personal note, John, was there ever a patient who gave you that kind of aha moment where either you thought it was FND and it wasn't, or whether you thought it was purely organic and it went into the FND area soon after? Any patient that comes to mind?
Well, neurology is a lot about diagnosis, at least it has been historically. And you do have to be very careful with diagnosis. And I do worry sometimes, whilst it's important to publicize FND, I worry about overdiagnosis or people rushing prematurely to diagnosis. I think FND, so people with functional paralysis, functional seizures, functional tremors, should be diagnosed by a neurologist who knows about all the many pitfalls. I'm sent quite a lot of patients to my FND clinic who turn out to have other things wrong with them, often quite rare neurological conditions. So I've learned over the years that really the first question you should ask yourself if you're a doctor and you diagnose FND, what other neurological condition does this patient have? Most of the time patients have rather minor neurological conditions like carpal tunnel syndrome or migraine or something like that. But I think it doesn't have to be an either or. And I would also just pick you up a little bit there, Kinjal, the use of the word organic. I think we have to stop using that word. Every condition that a human being has is organic. If someone can show me the non-organic bit of the human being, I will be willing to use that word. So I think we need to stop. So the opposite of a functional disorder is not an organic disorder. It's a structural disorder.
I think it is, for lack of a better word, that we start using organic or real. But like what you said right now, when we use a word like organic, it just means that the opposite is not true. It's non-organic. So I stand corrected, and I'm so glad that I have learned the word structural as against functional. I think I'll use it more often in the future.
I think any kind of dichotomy here is at one level false, because any change in function in the brain involves a change in structure. I think what I'd really like, functional disorders is the kind of least worst word at the moment, I think, for this group of disorders. What I'd like to see is doctors and health professionals just thinking of functional disorders in the same sort of category that they think of inflammatory disorders or metabolic disorders or cancer. These are sort of big categories of condition that human beings have. And I think functional disorders are just another one. So we don't need to put functional disorders in a separate box and then line them up against all of the others. They're just another category amongst 7 or 8 sort of super categories of human condition.
Totally. And also, John, do you ever have a feeling that FNDs are like a dustbin diagnosis, that people have tried to find everything else, nothing has come out of it, and so whatever is not there, it's not like a positive diagnosis, it's a negative one where nothing else is true, and so it must be an FND?
I think that's often how it's been diagnosed, and it still is. I know probably that's still the default position around the world, but that is not how it should be diagnosed. So it very much should be a diagnosis made on positive grounds by finding signs that are typical for the condition, which is what we do, when we diagnose migraine, for example. We find typical features of migraine. So in functional leg weakness, for example, we're looking for positive clinical signs. The pattern of weakness in functional limb weakness is very typical of that condition. You see a pattern of weakness that you don't see in other conditions. There are signs like Hoover's sign and the tremor entrainment test that are quite specific for FND. Or if someone's having a functional seizure, things happen that only really happen in functional seizures, particularly if you have lots of features together. So the patient might have their eyes tightly closed. They might have a seizure going on for 5 minutes, vigorous tremor-like movements, side-to-side head movement. So there's a whole range of clinical features that we look for that allow us to say, when we're hearing about a seizure or looking at a weak leg, and say that's typical of FND. That's how we should make the diagnosis.
Like a positive diagnosis.
I'm aware that many clinicians still will do lots of tests. The tests are normal and they say, oh, it must be FND. If you're doing it that way, you're doing it wrong.
Any specific reading material or any information that a caregiver might be able to access? Because I come across a lot of families where they have accepted FND as a diagnosis, but are really clueless about how to help the patient, about how much to kind of encourage them to get better, or how much to emphasize on allowing the diagnosis to linger. So what exactly can a caregiver do to make this better for the patient?
Well, I think the more that everyone really understands the condition, the better. So I think we do have material there now to help people with that. It's still, we could do a lot better. I would love to make time to make a lot better material, videos for carers, which we don't have really particularly. But I think there is some good material out there. Some on my website, but particularly, as I mentioned, these other organisations like FND Hope, and I would definitely encourage people to have a look at that and the videos there, and FND Action. It is hard. There are forums for patients with FND, but like most forums for anything really, it's often there's a lot of information. There's a lot of people looking for answers. Can be quite confusing. So I would probably stick to the main patient organisations and websites to really try and get your head around it, because I think a lot of the things that are helpful for carers to do come from common sense, actually, once you understand the condition. So, for example, if someone's having a functional seizure, people's natural and normal response to a functional seizure is to be very scared, because it looks scary. It looks like the person having an epileptic seizure and they might be about to die. Whereas if you know it's a functional seizure, then you know it's something where the patient brain is in a state of red alert, they've disconnected, the patient's having a very scary time, but the event itself is not dangerous. So then you can react to it in a similar way that you would, for example, a panic attack, which is everyone can be calm, just perhaps one person be there. Don't need to be anxious, and that often helps the patient with who's having the functional seizure. So that's a sort of example.
I think that's really helpful. Knowledge is power. Basically, people need to empower themselves with the right kind of knowledge so that they can help in the right way.
I think that's right, but I would also say that information, particularly online, only takes you so far. And we did a randomized trial. Well, Jeanette Gelauf, a really brilliant neurologist in the Netherlands, did a randomized trial, and I helped supervise her to see what effect just giving people information had. And what we found was that it did help. They were really appreciative of having, she made an amazing website in Dutch with lots of information. Patients really found it helpful, but it didn't change their outcome compared to people who didn't have that website. So we can't expect just to give people information and expect that to make them better. This is not, people need a lot more than that. So it's great that health professionals give people information now when they didn't used to, but it's not enough on its own. They need, these are complicated situations that need to be looked at, and everyone's very different and very individual. So people need individualized help and advice usually.
What exactly is the perfect treatment protocol for FND? Is there something like the perfect plan? Is it a neurologist's gamut, or does it come under some other disciplines? How is this to be dealt with?
Well, I don't think it's difficult to make a perfect treatment plan, but I think the big shift here is from thinking about this as just purely psychological treatment, which is where people were for this condition, to thinking about it as multidisciplinary treatment. So I think it's been really important for whoever's made the diagnosis to stay on board and help the patient understand that as best they can. That can't often be achieved in one sitting. So I think it's really helpful if a neurologist can see a patient again, go through questions, help them gain confidence in the diagnosis. I think we've learned the importance of multiple different therapies for FND. So if someone has a walking problem or tremor, then actually physiotherapy is often one of the best first treatments. So we're trying to retrain the brain. We're trying to change abnormal patterns of brain function, and you can do that quite well with physiotherapy if it's FND focused, because the type of physio for FND is different to what you would use in many ways to how you would treat someone with stroke or multiple sclerosis. And then the psychological therapy remains really important. So, for example, treating functional seizures is a bit like treating panic attacks. Has many similar features,
right.
Similar psychological therapies. Occupational therapy is really helpful in terms of focusing on activity, getting people to try and grade their activity over a period of time. People with these disorders often become quite withdrawn. They stop doing things because it makes symptoms worse, or they're worried about falling or having a seizure. So then speech therapy as well for people with speech problems, which again is different to people. Is different for FND than speech therapy for other conditions. So it's a multidisciplinary effort, really, and it's much more, from a health professional point of view, much more interesting for that, really, I think, that we have all these different facets of treatment. In reality, it's hard to access that, I know, and most professionals are not really sure how they can help people with FND, but we're trying to get the message out there, and there are consensus recommendations and documents about that you can find on the Neurosymptoms website.
I think this is also very important. What we usually consider is a neurologist and a psychologist. But like you mentioned, there are so many other fields which are involved and which should be involved for providing a holistic treatment plan to the patient. I'm sure this will help a lot of patients and doctors alike in rethinking the way they approach the treatment of FND once they have made a positive diagnosis. So thank you. John, what is the latest development in understanding FND in the brain from a purely neurological perspective? How far have we come now?
So I think we have made a lot of progress here. I mean, we've been talking about how we need to stop thinking about functional disorders as synonymous with being a psychological problem, and think about they're essentially disorders that challenge our views that the mind and brain are separate things. I mean, from my perspective, they aren't. It's just one organ, and we've made these rather artificial divisions. I don't think that there isn't a psychological bit of the brain and a neurological bit. So when we say to patients with FND, you've got a disorder of nervous system functioning, have we actually been able to see that disorder occurring in the brain? And I think the answer is yes, we have. We can see that people with FND, for example, who can't move their arms and legs, have different patterns of brain functioning to people who can. And they have different patterns of functioning to people who are pretending not to move their arms and legs, which is especially interesting. So we see in people with FND, their brains are actually working overtime on making movement. They're actually trying too hard to make movements usually. The more they try, the worse it gets. And that's familiar from our own experience of, trying to go to sleep, for example. It makes it worse. So there are a range of sort of networks in the brain that are going wrong, particularly networks that are involved in giving us a sense of ownership over our own body. So surprisingly, we need our brain to tell us that it's us that's doing things. We call that a sense of agency. And those networks have been shown in lots of different studies to be not working very well. And there are really intriguing ideas about how these different networks connect with each other, the networks related to agency, but also networks of emotions and networks of movement. And in fact, FND is a disorder that is teaching us about how the brain works and challenging our very ideas about divisions between brain and mind, neurology, psychiatry.
This is very interesting simply for the fact that everything is happening in real time. What we are seeing right now in the world is development in a particular field, which is so fast that people are doing the research, reaping the benefits, finding their own stumbling blocks, and then finding newer solutions, which is very interesting again from a psychologist's perspective, from a patient's perspective, that so much has changed. And like you said, there's so much more for us to know. I'm sure we'll know a lot more in the near future. But this is very fascinating. I personally didn't know that you could actually map the difference in a patient's brain with FND. So that's amazing. Thank you, John, for that absolutely delightful and enlightening conversation. I'm sure as we name it, we shall be able to tame it. A lot of listeners today have benefited from this podcast. I'm certain of that. Some have the right answers now, while some are equipped with the right questions for the next appointment with their doctor. Thank you for taking the time and sharing these valuable bits of information for everyone who has either known FND personally or has seen someone suffer. I'm sure we'll make the world a kinder place when it comes to treatment, thanks to the information that you have shared.
Thank you very much, Kinjal. It's been a real pleasure to talk to you.